And a reminder that all of these are recorded and you can see them on the BC Renal website afterwards. So next slide. Recognizing that we're hosting this session on the unceded and ancestral territory of the Coast Salish peoples, that includes the territories of the Musqueam, the Squamish, and the Tsleil-Waututh nations, as well as the Métis charter community of the Lower Mainland region. And wherever you are in this province or country, recognizing the lands that we're on, the commitment we've made to truth and reconciliation. And for those of you that haven't read the CMA response to and commitment to TRC. It's a really outstanding set of very concrete commitments that the medical community has made to all the Indigenous peoples throughout all the age groups in terms of righting the wrongs of the systemic racism within the system, as well as what we've done, not just in the system, but even in individual medical practices. I think it's quite sobering, but it's also a really important thing that I think we should all read. Next slide. So province-wide rounds, as you know, is a collaboration between the University of British Columbia and BC Renal in association with all of our industry partners, as well as all of you in the various health authorities, both geographical and non-geographical. We endeavor to make sure that we educate ourselves and our colleagues to the best of our ability to take best care of the people with or at risk of kidney disease. Next slide. So with great pleasure, it's really great to be able to introduce Dr. Janis Dionne. She's a pediatric nephrologist at BC Children's Hospital in Vancouver and a clinical associate professor at UBC. She served as medical director of pediatric kidney services since 2014 and is also the past president of the Canadian Association of Pediatric Nephrologists. She's been interested both clinically and in research in managing childhood chronic kidney disease and pediatric hypertension, and has actually been a member of the Hypertension Canada Guideline Committee and the International Pediatric Hypertension Association. She's co-chair of the Hemodynamic Adaptation Working Group in the International Neonatal Consortium, has an interest in neonatal blood pressure and outcomes after early life exposures. So with that, and obviously a breadth of experience, clinical and research-wise, it's wonderful to invite her here with the provocative title of Doc, I'm 40 years old, why are you asking about my childhood? So over to you, Janis, and thanks again for being here.
Oh, thank you for inviting me to speak. I will put up my slides. Yeah, so my cheeky title is essentially the punchline of what I want to talk about, but hopefully the details will come in the slides to come, and we can talk about why we think it's important. So I don't have any disclosures, and again, as Adira said, I'm privileged to live, learn, teach, and practice on the unceded territories of the Musqueam, the Squamish, and the Tsleil-Waututh nations. So my objectives for today are first to make sure that you understand some of the early life exposures that can have an impact on childhood and adulthood kidney and cardiovascular diseases. And then I'm going to show you some of the emerging evidence of the effects of childhood and adolescent hypertension on long-term kidney and cardiovascular outcomes. So this is essentially my outline. So in my work with neonatal hypertension, a lot of the work is looking at all of the antenatal factors and perinatal factors that can influence neonatal blood pressures. These factors are actually often the same ones that we need to think about when we're talking about childhood blood pressure. And in fact, they're often some of the important factors we should be thinking about when we're talking about adulthood hypertension. So this is a kind of summary of the literature that we have about the different kind of factors that can influence blood pressure. So there's maternal factors, there's perinatal factors, or things that happen around the time of delivery, and then there's infant factors intrinsic within when that infant is born. So there's a lot of small studies on each of these. There's not a ton of definitive evidence. Some of the ones where we are more certain about the effect in maternal factors is having a higher maternal blood pressure. You often have neonates that have higher blood pressures. There's been quite a few studies looking at the effect of maternal age. We don't think it has an effect on neonatal blood pressures. But there's also small bits of evidence for maternal diabetes affecting neonatal blood pressure, increasing it. Maternal smoking seems to fairly consistently have an effect on increasing natal blood pressure. So those are some of the things, and we really need to start collecting that information more on a more routine basis, so that we can more concretely say whether these things do or do not have an effect. And then there's a whole lot of things that happen around the time of delivery that can have an effect. So giving the infants steroids to quickly mature the lungs when there's premature delivery, that increases neonatal blood pressure. Some of the medications we will give the mums will potentially lower the infant blood pressure. But really, the strongest factors in the neonatal period, and you will see comes back again in childhood and adulthood, is the infant factors. So the gestational age that the infants are born at and the birth weight that they're born at. So in general, the lower the gestational age when infants are born, the lower we'll expect the initial blood pressures. The lower the birth weight, the lower we'll expect the initial blood pressures. And then as they grow in days of life, then the blood pressure increases with time. And a lot of these factors are what we're coming back to later on. So fortunately, maybe, most of the blood pressure hypertension that happens in neonates, if it's related to prematurity and all of the complications and issues and medications and things that are needed to be life sustaining, essentially, that hypertension almost always resolves in the first 2 years of life, which is good, right? Well, maybe not. Maybe the adaptations that are going on that allow that blood pressure to normalize, kidney function to normalize, all of that is actually maladaptive in the long run. So first of all, looking at these factors, how do they influence blood pressure in children? So studies that have looked at the effect of prematurity on clinic blood pressures have shown that they're higher in the preterm compared to those infants that were born at term, but they doesn't reach the point where you call it hypertension. So for most of there's a lot of studies that to demonstrate the different facts. So the way I've set my talk up is I'm going to give you the high level highlight, a summary of what comes from all of these studies in case you're the person that wants to know the summary point. And then I'm going to give an example if you're the kind of person that wants a little bit more details to trust what I'm saying is the summary. So for example, in one study at 14 years of age, they compared adolescents who were born very low birth weight, which they said at less than 1,500 grams. They had a higher blood pressure than term controls, but not more hypertension. But interestingly, they also had lower EGFR and higher albumin creatinine ratio. So already we're getting a little hint there that it's heart and kidneys that are affected by this. Studies that have used 24-hour blood pressure monitoring, again, they show similar or higher blood pressure in children who were born preterm compared to those who were born at term, but more nocturnal non-dipping. But again, it doesn't reach the level that we would define it as hypertension. So, for example, one study looked at children 5 to 7 years of age. Those that were born preterm had a similar 24-hour and daytime, but higher nighttime blood pressure. And in this group, 25% had elevated blood pressure, mostly at nighttime. And this comes back again and again where we see hints of future vascular dysfunction starting with the nighttime blood pressures. But the ones that had the higher blood pressures were also born growth restricted. So it seems to be that there's something different between just being born premature or being born premature or growth restricted, which we usually define as less than 10% of the expected birth weight or 2 standard deviations below what you would expect at the gestational age. So when we look at just intrauterine growth restricted populations and compare them, some of the better ABPM studies show that they have higher blood pressure and more hypertension. So already the ones that were growth restricted are showing hypertension in childhood. For example, one study looked at children already at just 6 to 10 years of age, and 18% of the small for gestational age had hypertension, where there was none in the appropriate gestational age controls, and elevated blood pressure in 50% of the small for gestational age versus 16% of the appropriate gestational age infants. And when they've looked more specifically at some of the vascular dysfunction, there is something different. So the children born small for gestational age have more arterial stiffness and endothelial dysfunction compared to those at appropriate gestational age. So for one study, they showed increased vascular resistance by pulse wave velocity and an increased vascular response to ischemia. So there's something different. We're getting a hint that premature infants have premature blood vessels, but if they're born growth restricted, it's usually because there's something else going on in that environment where they're being starved of nutrients or starved of blood, and therefore the adaptations are different. So IUGR infants seem to be different when they get older. And then there's a lot of controversy and discussion about the effect of growth. So catch-up growth, if it can be good, but too much is bad. So when we're talking early growth in the first couple years of life, in general, the higher blood pressure you get in premature infants, if they have a rapid weight gain for length over the first months and years, if you get highest blood pressure, especially if they're born intrauterine growth restricted. So, for example, one study showed kids at only 6.5 years of age who were preterm and low birth weight, and then had a very rapid catch-up growth in the first year of life, had higher blood pressures, but they also had better cognitive scores. So we don't know what the right amount of catch-up growth is to preserve the neurocognition, but not give them bad cardiac health for the rest of their life. When we're talking about later in childhood, it's a little bit different. So in older children, the effect of the rapid early weight gain still remains on blood pressure, but then the effect of their current weight or body mass index becomes stronger. So for one study, they looked at the kids first at 5 years of age, and they found a fair amount of blood pressure and metabolic abnormalities when they had a low birth weight and a high BMI. But by 10 years, the strongest factor was their current body mass index. Now, fortunately, the risk can be reduced with breastfeeding. So that's something that have always been an advocate for in pediatrics, but here's even more evidence why it might be important. And this is an interesting study from Miami where they looked at, so this is a cohort of children who had proteinuria, followed by a pediatric nephrologist. And a fair amount of the cohort, their only risk factor was being born preterm. So this top bar, the NOPT, are preterm born adolescents who were not obese. Compare that to this green one down here. If they were born preterm and they developed obesity, they lost their kidney function at the same rate as one of our most dreaded conditions in pediatrics, which is focal segmental glomerular sclerosis. So huge difference if they were able to maintain a normal weight versus whether they also had the added stress of overweight and obesity. Now, what about some of these early risks? How does that carry on when we're talking about the adult population? So, what about the effect of being born premature or growth restricted? So, in adults, most of the studies have not parsed out the difference between being premature and growth restricted. It's usually both of the groups are studied together. And so adults born preterm have higher clinic and ambulatory blood pressures and about a twofold risk of having hypertension compared to those born at term. In the young Finn study, adults, when they checked them at around 41 years of age, if they had been born preterm and small for gestational age, had higher blood pressures than preterm appropriate gestational age and more hypertension. And again, the vascular phenotype seems to be different between the just preterm versus the preterm who are also growth restricted. So the preterm have more arterial stiffness, presumed to be just premature blood vessels, similar to being born premature. A lot of things that should have had more time in utero to develop haven't had that opportunity. Compared to those who were small and the small for gestational age or extremely low birth weight, where they have a lot of endothelial dysfunction. And the vascular dysfunction of being born small for gestational age is equivalent to having a history of smoking. But it may not just be the blood vessels. So this is a newer study coming out, looking at other factors, looking at hemoglobin and their history of needing oxygen. So we know when you're born preterm, especially very preterm, you're at risk of having chronic lung disease, which is the new catch term for bronchopulmonary dysplasia. If you're old like me and learned that BPD when you were learning about neonatal stuff, preterms are a lot higher risk of having anemia, of needing blood transfusions. And because of their poor lung function, they often receive long-term oxygen therapy while they're in the NICU. So in this study, they looked at the adults who were born at less than 29 weeks gestation, knowing that lung function, probably 28 weeks-ish, is when you get good lung development. So most of those adults when they were born would have needed oxygen therapy. And they compared to those that were born at term. And the ones who were preterm had higher blood pressures, which we would kind of expect, and worse respiratory function, although not to the point of having a diagnosis of asthma or COPD. It was on lung function tests. The preterm adults also had higher hemoglobins and hematocrits, although similar EPO levels. And their higher hemoglobin was associated with having a full diagnosis of bronchopulmonary dysplasia, of having a longer amount of oxygen when they were newborns, and needing red cell transfusions. And they did a mediation analysis that showed about 35% of the blood pressure elevation in preterms could be explained through the hemoglobin level. So you're getting some vascular dysfunction and you're going to have abnormally high hemoglobin levels. So I know as nephrologists, we're much more tuned in to looking for anemia and low hemoglobin, but have a look and have a little pause and thought when you see unusually high hemoglobins for this case that you would, or the scenario where you would expect it to be. And then the effect of growth patterns affects even adult hypertension risks. So adults are more likely to have elevated blood pressure and hypertension if they were born with a low birth weight and then had a rapid catch up in birth or of weight over the first couple years of life. But usually the effect gets attenuated by the adulthood BMI, although there's also evidence that all of these things that are going on with being born preterm and growth restricted predisposes you to having higher body mass index. So it's not quite so clear cut. So for example, one study looked at adults 22 years of age, and the highest blood pressures were in those who were born small for gestational age and then had a very rapid weight gain in the first few years of life. And in fact, the blood pressure increased for each decrease in birth weight standard deviation score and for each increased standard deviation score of early weight gain. Although again, the effect was attenuated by adult BMI. And in one systematic review, again, they showed the similar thing. If you have early rapid catch-up growth after you've been born growth restricted, you had higher blood pressure, higher final body mass index, more insulin resistance. But again, better cognition, even at 17 to 26 years of age. So I don't think we're ready to discount the benefits of catch-up growth on cognition for cardiovascular risks, but I do think we have to figure out what is the right amount of catch-up growth to find the correct balance. And very interesting too is that this effect of rapid weight gain postnatally in one of these studies was in the Fells longitudinal cohort study, where they've actually been following these participants since 1929. And the catch-up growth was effect on blood pressure was most dramatic in the more recent decades. So earlier on, there was a lot more famine and problems with food security. And so the growth restricted, again, like I said, they're probably being born in an environment where they think that they're not getting the right nutrients. Maybe there's placental insufficiency, maybe there's maternal hypertension, and they believe they're getting born into an environment where things are restricted. But then if they're born into more recent decades, an area where the food is plentiful, then their body handles all those additional nutrients differently. It's like they're starved for it and they handle it differently. And the consequences on the metabolism and vascular system are much different. But it's not just the early weight gain that makes a difference. So this is again from the Fells longitudinal study. And so this top curve on the left shows what we would expect for growth velocity in a child. So there's a certain age of onset where they hit their pubertal growth spurt, and then there's a peak velocity in their growth spurt. And so the earlier the onset of the growth spurt, and the higher the peak, led to higher adulthood blood pressures. And the same, there's the bottom curve is body mass index. So at a certain level, childhood body mass index starts to increase more rapidly. And again, the earlier age that started, the higher the blood pressure in adulthood. So in fact, a prolonged juvenile state was actually beneficial. So this is the adolescents who start puberty late. Of course, adolescents hate that. They hate if they're not developing and their friends are having their growth spurts and they're putting on muscle, and they're the ones that are left behind. But if you remember back to your pediatric training, if you start your growth later, you end up at a taller adult height. So in the end, it's good. And here's evidence too that it's actually better for your vascular system for that to happen later on. Now, no adolescent is going to care about that, but if you're the parent of an adolescent, you might be happy that things are happening a little bit more slowly. And you get a lot more metabolic abnormalities, like I was saying. So adults who are born preterm, especially if they're low birth weight, have more components of the metabolic syndrome. So one study at 25 years of age, if the adults had been born preterm or extremely low birth weight, they had higher blood pressure, higher visceral body fat, higher fasting glucose and triglycerides, and lower HDLs, and poorer exercise capacity. So I don't think they're separate. They're all interrelated in some kind of innate programming, but it puts together to put a whole lot of additional cardiovascular risk factors into the same population. And we're nephrologists, so what about the kidney consequences? So this was a systematic review looking at the consequences on the kidney, the preterm birth, and they found that they had lower glomerular filtration rate, lower effective renal plasma flow, and higher urine albumin creatinine ratios without higher ureas, creatinines, or cystatin C. So interesting that you didn't get abnormalities in what we would traditionally look at as some of our renal function markers. Again, most of the studies that went into the systematic review were done either in childhood or young adulthood. So again, I wonder if there's some adaptive becoming maladaptive compensation mechanisms that are happening in the kidneys to give us a normal creatinine, when really what's going on underneath is a little bit more troubling. There was also smaller kidney volume and length in those preterm compared to term, and of course, as we've said before, higher blood pressures. And then there's a lot of other things that we should probably be considering. So, a lot of maternal conditions can have an effect on childhood blood pressures, not just infant blood pressures. So, higher maternal body mass index, often the offspring have higher blood pressure and body mass index. Mothers with gestational diabetes, the children and adults of those moms have higher blood pressure and more hypertension, and adult offspring of mothers with hypertensive disorders of pregnancy also have higher blood pressure and more hypertension. And then there's a lot of things that happen to these neonates, especially if they're born preterm, that can affect later kidney and cardiovascular health. So preterm infants with acute kidney injury have a lot more renal dysfunction, and it makes sense if you remember way back to your embryology. The kidneys are still developing till about 36 weeks gestational age. So that's pretty much almost term. So all of these infants who are being born preterm are being born before completion of renal nephrogenesis. So any additional insults you get can be very damaging. The neonatal group also often gets umbilical catheters, and if they get a thrombosis, they have a later risk of renal artery stenosis and hypertension. And every year we get a handful of children who have neonatal renal vein thrombosis. So if you remember back, the classic triad is hypertension, gross hematuria, a unilateral renal mass in a newborn, especially if they're born to a mom with diabetes in a situation where there's a low blood volume. They get often renal thrombosis. No matter what we do, whether we try to give medications to salvage that kidney or not, the outcome is generally the same, which is that over time they atrophy and there's a higher incidence of those kids developing hypertension and renal failure. So, what about some of the pathologic evidence for a mechanism? So, how do I convince you, if you haven't been convinced, of the fact that the adaptations are probably quite maladaptive in the long run for these patients? So this is just a slide to kind of talk about what happens when you're born premature. So as you're developing, the further in gestation you get more zones of glomeruli developing throughout the kidney. So the earlier or more premature you're born, the fewer of those zones of kidney glomeruli you get, and the further in gestation, the more zones that you have, like in the bottom left-hand side. And although, as you know, there's a lot of individual variation in different patients and different people and how many glomeruli they're likely to get in their lifetime. Now, if they're born premature, so this study compared those who were born premature and had some period of survival in the neonatal period compared to those who stayed in utero. So say comparing a child born at 28 weeks gestation who survived 2 weeks of life versus an infant who was stillborn at 30 weeks. So they both made it to 30 weeks gestational age. The ones that were born premature had more of those glomerular zones happening, but there was a lot more abnormal glomeruli in it. So essentially, if they're born preterm, they try to rapidly increase their kidney numbers. So they're trying to mature more quickly than they would if they had stayed in the uterus. But in that process of trying to do it quickly, you end up with a lot of abnormal glomeruli. And busy slide, I'll give you the punchline. So this also looked at those who were born preterm and tried to rapidly develop the kidney function. They found that they could do it, but probably no more than at 40 days of age. So no matter how preterm they were born, they only had a certain amount of time postnatal where they could try to rapidly improve the number of glomeruli they have. And if in that process they had any acute kidney injuries, which is particularly common the earlier in gestation they're born and the more sick they are, then it stopped. It stopped at that point. So again, a lot of abnormal glomeruli that are left, a lot of large glomeruli, probably hyperfiltrating, a lot of empty Bowman's capsules where there should have been a glomerulus, but now it's just a cystic dilatation. So the kidney tries to compensate, but in that process, it doesn't do it well because it's not meant to be in an ex utero environment yet. And so essentially, they're left with a smaller complement of functioning glomeruli going forward for their lifetime. All right, now I'm going to talk about, so that's about the neonatal blood pressure. Now let's go to childhood and talk about childhood blood pressure issues and how that might affect adulthood cardiovascular and kidney diseases. Now, Adira mentioned I was on the Hypertension Canada guidelines, and I don't know if anybody else has been a part of that process, but I will say it's intense. So they invited us to, so if family physicians across Canada were interested in having some guidance, like they have for adult blood pressure management, for pediatric patients that they looked after. So they invited a group of us to form a pediatric subcommittee. And so you, of course, you have to provide evidence behind the statements that you make in Hypertension Canada. So, reviewed thousands of abstracts, hundreds of papers, developed our statements. They go to the main Hypertension Canada committee who finesses the wording, and you can't say this and you can say this and you have to claim this level of evidence. And then you get together and you, with all of the different subgroups of Hypertension Canada, to present it, and you get questioned on, your statements and all the evidence behind it. And of course, there's very little evidence for the things that we would do for pediatrics. And they had decided, at the same time they were deciding to invite us to create these guidelines, that they weren't going to accept any statements that didn't have a very high level of evidence without randomized controlled trials or hard outcome data. So there is no hard outcome data in pediatrics. When kids get hypertension, our hard outcomes are left ventricular hypertrophy, increased carotid intima media thickness. They don't have heart attacks and strokes. So it was very hard to get our guidelines and recommendations through. There's a lot of indirect evidence, but it was not good enough. So let me walk you through what we know and finish with some stronger evidence that's finally coming out. So obviously, to try to figure out if childhood blood pressure affects adulthood health, you need really long-term follow-ups. The studies are so expensive. You need repeated measures, childhood through adulthood. So the chances of having these, there's not very many cohorts out there or programs with really long-term follow-up to actually prove this. So one group is the Fels longitudinal study. So like I said, they actually started these measurements in 1929 in this cohort in Ohio. They're following up through all of these years. So, and they're doing multiple measurements in childhood, multiple assessments in adulthood. So they found that having a high blood pressure when they measure them in clinic, they checked to see what the chances were that at 30 years of age or older, that the adults would have hypertension or metabolic syndrome. So there were some very strong associations or risks for having high blood pressures in childhood to having adulthood hypertension or metabolic syndrome. And down here, it shows that the more number of times at an assessment that there was elevated blood pressure, the higher that odds were of having adulthood disease. So I think this is pretty good, not good enough for Hypertension Canada. So also from the Fell's longitudinal study, they tried to look back and figure out what is a good blood pressure to have in childhood that reduces your risk. So this was looking for the risk of hypertension at 35 years of age. So the chart on the left is for males, the chart on the right is for females. Now, not a lot of females at 35 years of age are getting hypertension. So the risks were low for most of the female childhood blood pressure values. But for males, when they looked at what is a good blood pressure to have in childhood in order to prevent or have a low risk of having hypertension at 35 years of age, really, it was at the 50th percentile for blood pressure in pediatrics. And the higher you went in the percentiles of blood pressure in childhood, the higher your risk was for getting adulthood hypertension. So again, I think it's pretty good data, not good enough. So this is another longitudinal study that was looking at blood pressure measurements and cardiovascular outcomes starting at 2 years of age through to adulthood. And they were looking at the patterns of blood pressures. And they actually found that there were several trajectories of blood pressures that you could identify as early as 7 years of age. And they broke them down into normal blood pressures, high normal, pre-hypertensive, and hypertensive. So if you were hypertensive, even at 7 years of age, you had a really good chance that that was going to stay throughout adolescence and be your adult blood pressures as well. So the factors that were more likely to put you in those higher trajectory categories were being male sex, having a family history, being firstborn, or being born with a low birth weight. And then there were some effect modifiers. So things like increased body mass index or smoking gave you a chance of changing trajectory going to a higher level category. But again, evidence that the blood pressures that are happening in childhood are likely going to carry through to adulthood and it increased your risk. Again, evidence not good enough. So what about evidence of atherosclerosis, getting closer to a hard outcome? So this is from the PDAY study, the pathologic determinants of atherosclerosis in youth study. And so the factors that so this is people at 15 to, I think, 25 years of age who died of external causes. And they looked at their coronary arteries and their abdominal aortas for evidence of atherosclerosis. And then they looked at what risk factors they had. And so risk factors like age and gender and hypertension, smoking, things like that. And they found a fair amount of evidence, even at this young age, of atherosclerosis. And the more risk factors you had, the more likely you were to have atherosclerosis in your vessels already. So again, a young age for atherosclerosis, and already there's evidence of it. So again, I think it's pretty good evidence, not good enough. So what about kidney issues and blood pressure? So again, this was a longitudinal study. This one was in China, and they again looked at childhood blood pressures and chances of having subclinical kidney disease, so reduced eGFR, although nobody had overt CKD, or albuminuria in adulthood, based on what your blood pressure was doing. And they found several trajectories, although it was interesting because their trajectories they found in the analysis was a low stable, a moderate stable, a high stable, and a moderate increasing. And the highest risks of having kidney issues in adulthood were in the high stable and the moderate increasing. So maybe it's not just a single trend, but or a single level that stays over time, but maybe higher risk is if you have ones that are increasing out of proportion. And so I think in pediatrics, we need to do more tracking of blood pressures on similar to growth charts that we do to see where risks come in. And then this study came and this opportunity that I had to work with Dr. Rahul Chanchalani and McMaster and Cal Robinson. And so this is the population-based cohort study using Ontario Health Administrative data. The kids were 3 to 18 years of age, and they compared those who developed incident hypertension and matched them to 5 controls without hypertension. And we adjusted for every baseline covariate that we had of access to and could think of, so birth characteristics, medical comorbidities, things, and followed them up for 14 years. And then the outcomes they looked at were major adverse cardiovascular events, which included cardiovascular strokes and death and MIs and angina and coronary interventions, and then looked at some secondary outcomes. And so in this population in Ontario, there's about 7 million children. The median age at entrance to the study was 15 years, about 14% obese, 1.3 with chronic kidney disease, and these were very evenly matched between the hypertension cohort and the no hypertension cohort. And then the follow-up was for 13 years, so the median age at last follow-up was 27 years. So when Rahul and I were talking about this study, I said, of course it needs to be done. We don't have this evidence. We have to look, but if the data only has 13 years of follow-up and it's really quite young adults at 27 years, I'm not really sure we're going to have those hard outcomes to show. And I worry that it won't be significant. Well, the data and Rahul and Cal proved me wrong. So this study has been getting a lot of attention. So when we look at the major cardiovascular outcomes, the risks are twofold hazard ratio if they develop hypertension over time. 2.7 for having a stroke, 1.8 for myocardial infarction, 4 for coronary intervention, and on and on. So in fact, it actually showed these hard outcomes in this young population, which was quite striking. So wouldn't it be nice if in this group we could also look at their kidney risks? Well, hot off the presses, not yet published. Very kindly, Dr. Hassan and Chanchalani have shared the data with me, so you're the first to see it. Risks of chronic kidney disease. So this is the difference in the incidence versus of those who developed hypertension over the follow-up period versus not, and risks of end-stage kidney disease. So dramatic. So the hazard ratio for developing chronic kidney disease is almost 6. And for developing end-stage kidney disease, 9.6. So remember, 27 years of age was the average follow-up. These are young adults, and already we're showing that developing hypertension in childhood leads to these very significant adulthood events at a young age. All right. Now, just to finish it up, I'm going to talk about some of the childhood issues, kidney diseases that we recognize, hopefully, that could also end up in your clinics. So in terms of acute kidney injury, the most common causes in children are renal ischemia, often related to cardiopulmonary bypass surgery. So it's not bypass surgery because their coronary arteries are blocked. It's usually for congenital heart disease, so different, but still has significant kidney consequences. It's nephrotoxins, particularly in the oncology groups or kids that are in ICUs that are already sick, and then they get kidney injuries and nephrotoxins and sepsis. Other things to be thinking of that carry long-term risks of kidney damage are things like hemolytic uremic syndrome. So where probably a third of them have long-term sequelae. And these are tricky because often post glomerulonephritis, their urines can totally go back to normal, their creatinines can go back to normal, and it looks like they fully recovered. But years down the line is when they run into problems. And again, childhood cancer survivors, especially if they've had a stem cell transplant or Wilms tumor where they've had nephrectomies, those are kind of all risks for having kidney disease in adulthood. Now, in terms of the chronic kidney disease population, what I see in my clinic, 50–60% of my kids have CACUT, or congenital anomalies of the kidney and urinary tract. About 20% have some type of glomerulonephritis, and then another 10% have some cystic kidney disease, either polycystic kidney disease or nephronophthisis. Although I do point out here that with the arrows, that there are already some kids that have renal failure related to acute kidney injury events like cortical necrosis or medications or things like that. So that's the population that I'm seeing. A lot of the GNs progress on to needing renal replacement in their time with us, but the CACUT don't always. So they'll often be in your clinics as well. And so this is an interesting study by the European Renal Registry, looking at the CACUT patients and when they hit renal replacement therapy needs. So the left hand shows, so if I'm having, these are all the different types of congenital anomalies. If I'm having to transition them to you when they're 17, 18, 19, there are still a whole lot that are going to progress on to their kidney failure in the time in the adult clinics and not in mine. And you can see from the chart on the right, there is a peak in that late adolescent age, but there's a whole lot that are going to progress once they get to your clinics. And in fact, when the European registry looked at who was in the clinics, you can see these congenital anomalies make up a ton of the young age adults with kidney disease, and then with time, other diagnoses take over. And I'll just finish with this study that you may be aware of from the New England Journal. So this is a study done in Israel at the time of conscription to the Israeli army, and they do very thorough investigations of all of these adolescents at 17 to 19 years of age, and they do their medical histories, they do blood works, they do urine. So this is 17-year age group with a history of some type of kidney disease, and they looked at congenital anomalies, at pyelonephritis, and at glomerular diseases. But they had totally normal creatinine, no hypertension, no proteinuria. So these people would certainly not make it into your KCC clinic. In fact, you may not even want them in your general nephrology clinic if they have normal creatinine, no hypertension, no proteinuria, but just a history of having some kidney diseases. But followed over time, those patients with the history of kidney diseases had significantly higher rates of going into end-stage renal disease. Again, probably normal blood pressure creatinine, because some of adaptive mechanism is going on in the kidneys that ends up being maladaptive in the long run. So in summary, hopefully I've convinced you that these early life exposures can have an impact on the neonatal and childhood risks and cardiovascular and renal risks. There seems to be a differential programming if they're born only premature versus growth restricted. And from our point of view, we need to do a lot of education of families with high-risk infants to avoid obesity as a form of primary prevention. And hopefully I've convinced you that even in adult history and adulthood, if you take a history for your patients with hypertension and renal disease, try to include their perinatal course and their childhood events, because you may actually end up having less kidney disease of unknown origin or hypertensive kidney disease, and you may actually find more causes if you go back further in their history. And with that, I'm happy to take any questions.
Thank you. That was great. Very informative and educational. There were some questions that were in the chat, so I'll give people a chance to put up their hands as well. I think you did answer it, but I think just to clarify, that nephron number is related to kidney size in relation to body size in these young kids. Like that's the whole Brenner hypothesis, right? Or is it not so simple as that?
Not so simple, because there's such a genetic variation in numbers, but certainly the more damage, the earlier they're born, we know there's fewer, and we know in general those kidney have lower lengths and volumes, but I don't know if we've proven it one-to-one.
Great. There's a question from Dr. Elliott. Great talk. Most adult patients don't know very much about their perinatal health. Is there a way that we should be asking to elicit this better?
Yeah, I was thinking about that. I was thinking, from the ones that transition from our clinic, I know you probably don't particularly like their parents joining and we're trying their clinics and we're trying to teach them to be independent, but maybe for the first appointment, it wouldn't be the worst thing in the world. And or for your older patients, could we, when you send those lists of things that you want done ahead of time with their labs and things, could you, get them to find out their family history and their early childhood history before coming into clinic?
Yeah,
I don't
no,
know.
it's interesting. I had just anecdotally, I had identical twins with Alports, and one of them was progressing much faster than the other, and I couldn't figure out why. So I brought them in, and their mother came at the age of 40 for her sons to get biopsied. Of course, I then asked her which was the smaller twin,
Yeah.
and so then that was part of the answer. Yeah, I think the other thing that I was going to say is I was quite intrigued with the female versus male non-predicting of hypertension. That might be, there's a newer document where female hypertension has a different cutoff than male hypertension. So if you use the male hypertension cutoffs, there's probably no relation, but it'd be really nice to redo that study,
Mm.
looking at the different cutoffs for hypertension in females, especially at 30 plus age, and see whether or not it does impact, because it probably, it doesn't make sense that it
Yeah.
doesn't in that respect. Um,
Yeah, and I mean, we do that in pediatrics. So our blood pressure, I mean, we've gone to thresholds, but before we went to threshold cutoff, similar to the adults, it was all based on percentiles. And when you compared the percentiles and populations of the so it's the same up until you hit puberty, essentially. And then at that, the men have higher blood pressures than the girls do, or the males do than the females do. So if we use a percentile, we expect the female's blood pressure to be lower. So that makes a lot of sense that that would carry into adulthood.
right. Yeah, very interesting. No, I think there's a lot. I mean, I guess, in a province like BC where we do have the transition of your folks, but also the perinatal registry and various other things, we should be able to look at even an estimate of burden of illness or expected burden of illness from similar to what they did in Ontario. I might think it would be interesting to look at,
Mhm.
right? Because not all of them come to you, as you said, but if there was a way for us to look at this, and I guess alerting parents without upsetting them that these are risks in later life, and how do you remember something that happened 20 years ago that might have an impact.
Yeah, and I mean that's part of my trouble is that as well is just the education because of course, everything that's happening if they're in a neonatal unit is life threatening, right? So
Right.
the parents remember all of the life threatening things, and what they're worried about if they're born preterm is their neurocognition. So the follow up and the advice as they leave all has to do with we're going to assess your development at this age and they knew that they were on the ventilator this long, but nobody ever tells them, even the neonatologist, that, you're born at 28 weeks, but really your kidneys weren't supposed to be developed to 36. So I often get them in my clinic later on, and I do an ultrasound, and the kidneys are echogenic and small. And I'm kind of like, yeah, it's kind of as expected. And the parents are like, what?
Yeah.
It's first I've heard of it. I don't understand this because it's all about the life saving, and you don't get to talk about a lot of the other things at that point.
Yeah. And nor, I mean, I guess the anxiety, et cetera, is probably, there's a balance of how much you're trying
Yeah.
to get people to manage. But I do think maybe, as GPs or pediatricians that are seeing these people later, like after the acute event, perhaps some awareness that is really important. And I think it's really great for us to think about all the things that are occurring in these younger folks when we're seeing them at 25, 35, et cetera. But thank you very much for tying together pathophysiology, epidemiology, and putting it all together in a really nice package for us. Very thought-provoking and very interesting. So yeah, thanks very much, and happy Friday,
Thank you.
everybody. We're right on
Yeah,
time.
great.
Thanks
Thank you.
again. Bye. Bye.
Bye.